Welcome to today's speaker series. Thank you all for joining. My name is Rosa Staltieri, and I am the Knowledge Translation Manager with CanCOVID and also the speaker series moderator. It is a great pleasure to welcome Dr. Mel Krajden, who will be presenting on real-time integration of diagnostics and genomics for guiding our public health response. Dr. Krajden is a medical director of the BC Centre for Disease Control Public Health Laboratory, a professor of pathology and laboratory medicine at the University of British Columbia, is also currently a member of the Federal COVID Immunity Task Force, a member of the Health Canada COVID-19 Testing and Screening Expert Advisory Panel, and also facilitates the Testing Working Party. So before we get started, there's just a few things to note before every presentation. We just ask that you ensure that your microphones are on mute during the presentation. And we also welcome you to use the chat box at any point during the presentation to ask a question or provide a remark to facilitate some conversation. And we also just ask you to keep your, you can keep your videos on during or after the presentation. And if you'd like to answer or ask your question live, we also welcome you to do so by raising your hand. So without further ado, I will hand over the floor to Dr. Krajden.
Thank you, Rosa. So on this first slide is an illustration of the creation of a dashboard that actually allows us to track who's been tested, where they are, what the results are, who's hospitalized, who's in critical care, who's died, and what are the turnaround times and positivity rates and things like that. And on the next slide, you have a detailed representation of the daily cases per 100,000 population by different regions of the province and the testing rate per 1,000 population. And it really does show you the kind of integration that can be brought together that tells you what's going on in your province or indeed the country in real time. And it's that kind of information that can help you respond to the pandemic in real time. And the reality is those data sets involve pulling data from a patchwork of poorly interoperable systems. And this diagram illustrates that you're actually bringing data from lab systems and health authorities and processing them into other data sets. And then these are then used to create those dashboards and also the reports that go to the federal government. And it just does illustrate how if we wanted to do this prior to COVID, this kind of integration would have taken 5 to 10 years to get approvals as to whether you could share data X or data Y. And COVID, the only good thing about it, has massively improved our ability to share data from systems that exist in the province. And we hope that they'll be sustained after this pandemic is addressed. In terms of diagnosis, we all know that the diagnostic mainstay is nucleic acid testing. And nucleic acid testing is about 90 to 95% sensitive. The specificity is probably in the 99.5% range. And so why do we hear that PCR is only 70 to 90% sensitive? And part of that is it depends on the stage of illness. With early infections, you may miss it. In some people, you have a predominant lower respiratory tract infection and you won't find it in the throat or nasopharynx. Or with late infections, you shed virus for a number of days, typically at least 20 to 30 days on average, and you're not necessarily have a cultivatable virus. The sensitivity studies have been limited, and the sampling technique is important. So doing a nasopharyngeal swab, it's important to collect it properly, and you see people doing brain biopsies, but you do need to have some sampling of the tissue, and it is important to collect it properly. In terms of Nasopharyngeal swabs, they're likely more sensitive than throat swabs. And because of what initially occurred in terms of global swab challenges, and also because of the convenience, many jurisdictions have switched to saliva, and we've switched to saline, swish, and gargles as a mechanism of reaching to younger individuals, kids over the age of 4, and also to make it easier on workers who are getting repeat screening. The false positivity rate is, I mentioned, 99.5%. And so about 1 in 200 will be a false positive. And most of these are actually technical errors rather than the test picking up a positive. While I'm not a fan of Michael Mina, this slide illustrates a very important concept. So with PCR, you can detect people very early on in a pre-infectious state, and then you can detect people later on in what we would call a post-infectious state. And that is helpful, but his emphasis in that work is that if you use lower analytic sensitivity tests, such as antigen tests, you will pick up most of the people who are expressing large amounts of virus, high viral loads, and those are the people who are most likely to transmit. And that data is also supported by a publication recently by Pecos et al., and basically showing you that if you look at the sensitivity of various technologies, the PCR is the most sensitive, the antigen test is significantly less sensitive, but it aligns very much with cultivatable virus, and then cultivating on different cell lines is even less sensitive. So where would we use this? So point of care rapid antigen tests, or RATs, have value. They are basically antigen detection immunoassays. They typically take about 15 minutes. The good ones have sensitivities in the range of about 60 to 75% relative to PCR, and they are probably as specific as PCR. So the specificity is in the 99.5% range. They are adequately sensitive for people with high viral loads, and therefore they provide a screening approach that could be used for asymptomatic or pre-symptomatic infections, particularly when people are in high-risk settings or in congregate settings. And the important thing to know, however, is the pretest probability is important. And what people don't often realize is the sensitivity and the specificity of a test is really a test characteristic. And the predictive value, on the other hand, is a population characteristic. And the principle is, if you have a low prevalence population, particularly people with asymptomatic infection, asymptomatic exposure, no risk of being exposed to someone with COVID, they're a low risk population. And so when you do these rapid antigen tests, it's important to think about what are the transmission risks. Are you dealing with a true positive or a false positive? Because in a higher prevalence situation, you're going to have more true positives in terms of predictive value. And in a low prevalence population, you're going to have small numbers of true positives. They're going to be more false positives. And so in the context of using these rapid antigen tests, it's important to think about when do you use PCR to confirm them. And that's going to be important for whether someone gets placed into quarantine for a period of time or is told to stay home versus what's the risk of transmitting infections to others. Training is also important for test accuracy and to protect the person performing the test, because they need to know how to use PPE. And at the same time, there's a push towards the use of self-collection or even self-testing as a way to reduce resources in the people who are doing these tests. I'm going to switch to whole genome sequencing. If you were back in early 2020, you saw in British Columbia that the B1 and A1 were the dominant linkages that existed. And this is work by Richard Harrigan and Natalie Prestigiecki. And we were doing whole genome sequencing to look at ongoing community transmission, to look for repeated introductions of new strains, and also to understand whether you had multifocal transmission clusters. If you go back to February, essentially, of January, February of 2020, what we saw was most of our transmissions were related to introductions from the US and from Europe. They were not from China. China had already locked down its system. And one of the pivotal cases was to detect a case related to travel from Iran, because that case illustrated that this notion of trying to case find individuals who had traveled to China was no longer valuable, because the virus had essentially been transmitted globally. If you look at whole genome sequencing now, and this is a beautiful illustration from Public Health England, what you see is that we are looking at viral evolution in real time, and we've never done this for a virus or a pandemic. So the challenge for us is to say, well, what is signal and what is noise? And this is an important point. And so we now see lineages, and lineages represent sequences that are clustered around original virus that has originated in places like the UK, South Africa, Brazil, New York, California. And some of these share this N501Y, which you can use to target PCR. And the N501Y is associated with increased transmissibility. And in the UK, that's been a major concern. Others lack the N501Y, but harbor the 484. And that's an important consideration, because the 484 is associated, as an example, with antibody resistance, either through monoclonal or polyclonal therapeutics, or to vaccines. And this illustrates, for example, that in this case, you have the UK variant and the South African variant and the Brazilian variant, all of which actually share this 501Y. But as I'll show you shortly, we have variants that originated from Nigeria, which do not have this 501Y. So we'll talk about that in a moment. In terms of our own sequencing efforts, we've sequenced greater than 12,000 genomes and almost 4,000 since January 3rd to the end of Epi Week 7. And our capacity is about 750 genomes or samples per week. And we're applying a multi-pronged sequencing strategy, looking at outbreaks in long-term care facilities where you tend to get much more homogeneous sequences, hospitals where you get more heterogeneous sequences because the introductions are from more than one site, and schools. And we are also doing targeted surveillance for pediatrics and travelers and temporary foreign workers. But I think the important piece is doing background surveillance, which is essentially random samples where you're trying to be as unbiased as possible, and you're looking for variants of concern that could be introduced into the country or the province, or they're evolving in your own doorstep in your province or country. We, like other jurisdictions, are testing or screening by a direct PCR for the 501, which can be helpful to detect the UK, the South African, and the Brazilian originating variants. And so we use that as a presumptive variant of concern screening tool. And then when they're positive, we will then confirm them by whole genome sequencing. To speak a little bit about the variants of concern, we have the very important one from the UK, the B117, and that's been shown to have increased transmissibility, potential increased severity, and the increasing case numbers are straining health systems. And there's some data that we sort of stopped the declines in transmissions across the globe, and this may be a reflection of the UK variant, which is more transmissible. There is no strong evidence for decreased vaccine efficacy, and I mentioned about the main mutation in the spike, and it has other mutations. And the B1351 lineage, it originated from South Africa. It has no specific impact on disease severity, but that may be the studies that have been used. It also has a bunch of other impacts on the spike receptor binding domains, and at least that lineage does. And there's evidence that the mutation in the E484K alters neutralization by polyclonal and monoclonal antibodies and alters vaccine effectiveness. In terms of the lineage from Brazil, that's a very interesting lineage because about 42% of specimens from Manaus, Brazil, were COVID-2 positive during a subsequent wave in a population where people thought that the seroprevalence was about 75% as of October 2020. And here again, there's mutations in the spike receptor binding domain, as well as other regions. And then in BC, we have some lineages that are localized that are in this E484 region. We have some that have been derived from Nigeria, as have other provinces. And one of the challenges is we need to better understand both BC's and Canada's virus lineages and variants. But in order to do that, you have to be able to statistically power these, what I would say, molecular fingerprint correlates with the epidemiology. And you can see in the UK, it took a while for them to get a good sense about this UK variant and how it led to increased transmissions, didn't necessarily impact vaccine responsiveness, and may have had more severity. Next slide. In terms of the B117 in preventing severe disease, if you look at the overall estimate, it's about 50% more transmissible. And if you look at the R0 in the UK, the R0 was felt to increase by about 0.4 with a confidence interval of 0.24 to 0.55. And it led to exponential growth that occurred in Britain when the R0 in the background population was 0.85. And in BC, where R0 has been hovering around 0.95, we would expect this variant to increase the R0 to 1.35, and we would expect a doubling time of somewhere around less than 10 days. The high secondary attack rate in the UK did also occur during strong public health measures, and they noted 30 to 40% more transmissions and higher rates in certain age groups, and there were more within household transmissions. If you look at the Ontario Science Table update from February 25th, and this looks at essentially the UK versus other parts of the world, and then in Ontario, what you see is a very rapid increase in the UK variant in that region of the country. And it takes somewhere in the range of 6 to 8 weeks to grow from about 5% to greater than 50%, even in the context of high public health restrictions. In BC, we are already over the 1%, and we could have potentially a few weeks of low rates of infection, but it's likely to be a race between these variants of concern and the vaccines, and hence the push to try and get more vaccines into as many people as possible. And this is an illustrative figure where we're looking at the epidemiological week, and we are looking at whether or not the introduction of the B117 was travel related. And then you can rapidly see that the travel related, which is light pink, versus dark pink, which is no travel. And you can see that most of our cases of the UK or B117 variant is actually related to community-based transmission, and the travel link is gone. And in contrast, if you look at the introductions from the South African variant, what you see is while they were early on travel related, some were non-travel related, but it has not really taken a foothold in British Columbia. And then the travel related cases related to the variant associated with Nigeria, and it's not considered a variant of concern in North America and parts of the world, but in the UK it is considered a variant of concern. So basically what this illustrates is that in British Columbia, we too are going to be having more and more of this UK variant, which is easily transmitted and likely going to replace the strains that we see circulating. So I think what we have to recognize is that we are in a five-way race, and we have the public who basically is tired of this pandemic. I've had my patients tested and I'm negative, but the public is extremely tired of this pandemic and wants to move on. We have this virus that is having fun doing what it does best, which is to evolve mutations. And we are looking at those mutations with a scrutiny that didn't exist before WGS. And then we have vaccines, and there are a whole slew of these vaccines, but they're in short supply. We have all of the problems of getting those vaccines into people. And then some of the estimates of how long it will take to vaccinate the rest of the world is multiple years from Bloomberg news media. So the five-way race is: how do you work with the public? How do you understand the variants? How do you figure out how best to use vaccines? How do you get them into people? And how do you support the rest of the world? So this is some very, very interesting data published last week in the New England Journal. Many of you have already seen it. It's the Pfizer data from Israel in their nationwide mass vaccination setting. And it, through sheer brute force of unvaccinated and vaccinated controls, has documented that you have incidence declines from vaccination, declines in symptomatic infections, declines in hospitalizations, declines in severe disease, and declines in deaths. And this really was done with a massive number of people, of more than almost 600,000 in cases and controls. On the other hand, we have some really neat data that's come out of both Quebec and in British Columbia. This is some of the work led by Danuta Skowronski and presented to NACI. And it looks at this substantial decline within a few weeks of the first vaccination, both in healthcare workers and in long-term care. And what she has done and her group has done is to basically looked at what the baseline prevalence was and showed that it was fairly stable, and then assigned as time zero when a group of individuals, healthcare workers or long-term care residents, were vaccinated, and then tracked what happens in terms of not only infections being diagnosed, but severe disease. And what you can see is a dramatic drop. Here the N is only 346, and for long-term care, it's 203. And you see this dramatic decline even after the first dose in both of those different populations. And you can imagine that long-term care facility residents are older versus healthcare workers that tend to be younger. So in conclusion, the SARS-CoV pandemic is a moving target that has devastated people and economies. Testing, tracing, and public health measures work. and we need to refine them to improve case and contact management, which is difficult with a tired workforce. We are observing with unprecedented genomic evolutionary scrutiny these emergent variants of concerns, which increase transmission, sometimes increase severity, and some alter vaccine or immune response. We have effective vaccines, which lead to the challenge for us is supply issues. And will variant of concern lead to a third wave? BC and other jurisdictions have taken bold steps of delaying the second dose to get more people immunized. And will the slow global vaccine rollout put selective pressure on the virus to develop additional variants of concern? In conclusion, further conclusions, there's a cacophony of mixed messages, and the solution, I believe, is learning how to use real-time integrated data to monitor the epidemiology, anticipate and model the challenges, and respond based on synthesized real-world data. We have the building tools to monitor for vaccine efficacy and durability, look for reinfections, look for vaccine failures, vaccine escape mutants in real time in a real world settings, and that comes from the integrated data sets. And we need to partner to assess and monitor for immune correlates. I think I will leave it at that and thank everybody.
Thank you so much, Dr. Krajden. I thought, going back to that five-way race, I thought that was really nice that you highlighted that on regarding vaccines. So, but we do have about a couple of minutes for questions. So I'll get started. I don't see any hands up right now, so we'll start with the chat box. So we do have just a note there. The accuracy of the PCR test also depends on how many cycles of amplification are used. High numbers of cycles beyond around 25 cycles reduces accuracy, but increases sensitivity. So we do have a question. How much current sequencing capacity would you like to have?
I think the challenge of it's not so much sequencing capacity. I think the more important question is having good ways of integrating the sequencing that does take place with the epidemiological information. And I think that we've done a lot of sequencing in British Columbia relative to some of the other jurisdictions, but it's really about the strategy of the sequencing. I think the use of direct PCR is complicated because the virus is evolving. And if you look for one particular region, the virus may evolve and then you need to adjust that all the time. But I think it's more about really being able to share data and share the epidemiological information so that you can come up with the appropriate powered studies to understand how important is the variant in your environment.
Thank you so much. We have a hand up by Munir. Apologies if I pronounced your name incorrectly.
Munir Abu Haider, yes. I'm curious to see if somebody did the sequencing of a virus from a patient in the beginning of the infection and later on, whatever, a couple of weeks, 3 weeks or whatever, took another sample and sequenced it and see what kind of evolution and kind of mutation happens in a single individual.
They have done that, and they did that in the UK, and it's felt that the UK variant probably originated from someone who's infected who is immunosuppressed. We've done a bit of that sequencing, so you can get some mutations. And if you look at the outbreaks in mink that occurred in Denmark, you can see mutations that occurred when mink get infected, and there's these adaptive mutations in mink. So yes, you do get variations in an individual, but remember, as you clear the virus, it becomes harder and harder to sequence because you need to have enough viral load.
Yeah. Is anybody, I may take another question, anybody looking at all these pets which we have, like cats and dogs, and I'm kind of worried, I have no basis for it, kind of worry if the virus can go back and forward even without noticing it. and maybe having mutation. Is anybody into that line?
There was a whole genome sequencing showing transmission from a human to a cat, I believe.
Yes, I know.
So yes, and you can get it amongst different cat families, and you can get dogs infected as well. And one of the concerns, in fact, when mink get infected, you can also transmit it to other zoonotic mammals that are associated with mink farms.
Yeah, I'm aware of that. That's why I'm asking if it's any in Canada, in your place and whatever, if people may be worrying and see what's going up, what's happening into the pets. I don't see anybody taking sample from pets like cats and dogs and see what do they have.
Yeah,
Well,
I think they're worried about the humans at this point.
Yeah, but it's fired back to humans. So anyway, thank you.
thank you, everyone. We are out of time, so I do want to close. So just want to thank you so much, Dr. Krajden, on behalf of the CanCOVID team and network. We thank you for your time to present to us on this informative and timely research. And we do have just one announcement next week, which is on Tuesday, March 9th at 4 p.m. Eastern time, so the same time as the speaker series is hosted. We will have presenters Ronald Labonte and Arne Ruckert from the University of Ottawa, presenting to us on the Canadian policy response to COVID-19 and what it is in it for health equity. So thank you so much, everyone, for your time, and hope to see you next week. Bye for now.